Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the Heart of Healthcare podcast. Today, Michael and I are talking with our friend Rebecca Mitchell of Scrub Capital. Rebecca began her career in global health as an academic researcher and Fulbright Fellow in maternal health. She received her medical degree from UCSF, where she focused on primary care innovation and the role of technology in medicine. She then served as the medical officer for innovation at HHS before returning to Silicon Valley, where she spent a decade in product roles at startups, including Livongo, then Teladoc post-acquisition. Rebecca now leads the new early-stage fund, Scrub Capital, a unique model that incorporates the expertise of over 700 clinicians, founders, and operators to invest in healthcare companies. That was a long bio, Rebecca. You've done so much. Thank you. Thank you for being here.
Thank you so much for having me. Really looking forward to this conversation, you two.
Thanks, Rebecca. Thank you so much for joining us. Okay, so what an incredible storied career to date. What an amazing trajectory. So the obvious question for many of our listeners is, what inspired you to move from clinical product leadership roles to venture?
Yeah, so I've answered this question probably 10,000 times over the years. And similar to a guest you had on recently, the co-founder of Oak Street Health, I loved his perspective on this, which is that you can go through people's resumes and pretend that they're linear, right, and well thought out, and they absolutely never are. So I'm going to answer the question, kind of going back to first principles on my why for everything I've done, because none of it has been linear steps, right, that actually made sense and were pre-planned out. So really, it's been three things. One is going back to the fact that I spent the first half of my life, I just turned 40 this year, big 40, and I spent the first half in very rural, very northern Wisconsin. And by rural and very northern, I really mean it. There were more dead fish and animals on our walls than pictures of our family. The lake was frozen half the year. My hair froze on the way to school, real deal. Also had all of the cliche kind of healthcare issues going on because of how rural it was. Really religious community, and we still had the highest teen pregnancy rate in the country for quite some time. We were on Jay Leno a few times, a butt of many jokes, on talk shows because of it. It was that bad. Hospitals constantly closing down and reopening, 6-month wait list to see specialists. Continues now. I'm constantly signing my parents and friends up for virtual care programs every time that I go back, some of which I've actually built myself, which is very funny. My parents finally understand what I do because of that, finally. My why, number 2, I lost 2 family members in the first 20 years of my life, really tragically, really due to ridiculous medical mistakes, but people doing good work in a system that is overburdened and not set up for them to do good work. One was my grandmother, who was taken off anticoagulation mistakenly after having a carotid endarterectomy, and the other was my 17-year-old cousin, who was not diagnosed efficiently with leukemia despite presenting to his pediatrician 5 times with classic symptoms, awful circumstances. And both of those things, both of those experiences really caused me to recognize in my early 20s when I was at medical school at UCSF, an amazing institution in an amazing location in the Bay Area, that this current model of training people, right, for 10 plus years, sometimes 20 years for some subspecialties, these people who are deeply passionate, brilliant, dedicated to what they're doing, putting all of the scientific knowledge, care delivery knowledge into their brains, wrapping them with other deeply passionate people who are slightly less trained, or wrapping them in deep administrative layers, guild-like behavior, bureaucracy, and then saying, okay, patients, break through that, or travel, in my parents' case, 3 hours and then break through that to receive care, not working, right? Which gets to my third why. Being in the Bay Area, being allowed to hang out in places like Rock Health, Hallie, when you and Nate were first starting it, right, in the Chinatown office, working with companies like Doximity, working with some of the projects at UCSF that were taking place at that time, and seeing what was possible when you started from first principles and got a bunch of different people around the table, product designers, engineers, commercialization experts, and clinicians to rethink medicine from first principles, you could really approach solving the problem in a totally different way. And I saw it was possible over and over again. I saw that 80% of it didn't work, kind of maps to, right, like the percentage of companies that don't work when you start them. But enough of them did, that there was real progress to be made. And I made the decision in my mid-20s that that is what I wanted to spend my life doing. I didn't want to spend my life as a person kind of continuing on in the model that I saw breaking over and over again within contexts that I'd grown up in and cared about. And so everything that I've done in the last 20 years has been further attempts at trying to create something better, but working alongside and enabling the people that continue to be dedicated to serving patients in the here and now in the process and taking their knowledge and their humanity, right, and building something better along the way. So the product work was that, and we can talk a lot about how we in those companies incorporated clinicians deeply in the process of inventing those products and selling those products and improving them. And the work in venture is just as much taking those learnings and bringing it into the world of investing in those companies and supporting them in their earliest days.
You're known as like the product doc, which I think is a fun tagline, but you were probably the first medical doctor to get a product management role at a digital health startup, at least one of the first. I'm curious kind of those conversations when you were exploring those roles, how you positioned yourself to compete against folks that came from more traditional product backgrounds.
So I got into it very, very sideways. So when I finished medical school, also funnily, Hallie, like tie into your work at Rock Health, I ran into Todd Park backstage at one of the Rock Health conferences and shared with him what I was intending to do with my career. And he really encouraged me, as of course a multi-time successful founder himself, to spend a bit of time understanding how the sausage was made and who all the other stakeholders were, in addition to like the medical institutions and the practice of medicine, if I wanted to build products, build care models, build companies. And he, invited me to explore coming to work in Washington, D.C. in the HHS CTO's office for a few years, where he had just taken the CTO role. He, of course, was then almost immediately promoted into the White House, which I couldn't follow him into. But I did end up working in the CTO's office for a few years, which then led me to Code for America, where I worked amongst some of the most talented product leaders and designers and engineers that exist in Silicon Valley that wanted to spend several years applying that to public service and specifically making public programs work much better. And that's really where I learned how to be a product leader and to work alongside engineers and designers and others and bringing things to market. And that was really what allowed me to transition into product roles in startups. But even then, really in the early days, I was hired for my ability to translate and be the bridge between clinical teams that were doing, back then they were, and even now, unfortunately, they're often doing things like writing documents that are handed off to the product teams and the engineers to go build things, or they're the check mark at the end, which is not how it should be done, to be very clear. But I would be that bridge between the two. And that is even what I was initially hired to be in some ways at Livongo, and then we evolved the model over time. But yeah, I was one of the first people that was officially on the product team, reaching over into the clinical team, rather than on the clinical team, right, like handing things over into product and engineering.
It's fascinating, Rebecca, because I remember those early days in Rock Health's Chinatown office, and there was a real sense in those early years of this amazing industry that we're all now so deeply invested in, that technology was going to go around the clinical teams, right? That in some ways, you even heard from really well-known venture investors were saying, we don't even need the doctors. Technology is going to replace the doctor. We don't need the clinician's input. And so in many ways now we've seen that come full circle.
Yeah. So I would bring it all the way back to this conflation between what is the problem you are trying to solve and the expertise and experience required to solve that problem in a new and better way versus do we have to keep replicating the current solution to the pre-existing problem? And people conflate the two things when they talk about, are we replacing doctors? Are we going around doctors or clinicians? And what is their role, right, in these technology companies? I absolutely believe 2 years from now, 5 years from now, If you ask anybody and you talk about 500 years from now, will the role of any clinician out there look completely different 500 years from now? You cannot find anybody that would say, no, it will look the same, right? Like nobody will say that. So the real discussion is on what timeline will it look completely different, right? And how do we get there? And what I very strongly both believe and have seen every single time I have ever designed, built, and sold a product is that you get there faster, better, and more sustainably when the people who have the medical science and the direct care experience at the table as an equal, not as the person at the top of the pile, not as the person who's the last one at the end of the line asked to review it and approve it or just to buy it, but as a peer at the table, like it all works better. You're going to make more money as a business, you're going to do better for your patients, and you're going to be a sustainable company like over the long term. And it takes, though, finding a clinician who wants to participate in that way, right? Who's like coming back to the deeper reason that they got into medicine in the first place. And it's not about my job has to look the same forever moving forward. It's that my job is to bring health to as many people as possible, right? As cost effectively as possible. Like that is my job. And I believe that I will have a job, right, if I keep that front and center. And so will my colleagues.
So the question I've asked you before, and I love your answer, so I'll ask you again so that our listeners and Michael can hear how you think through this. We obviously have a clinician shortage crisis that we are facing. Our doctors, nurses face higher rates of burnout. They're working longer hours. They're less satisfied. They have higher rates of suicide, major issues. So it's no surprise that if there are other opportunities to get back to their mission of why they're in healthcare in the first place, that a lot of them are choosing to do so. And we're seeing this. But then doesn't that worsen the crisis, the shortage to begin with?
Yeah. So I would say, unfortunately, in the short term, both things are true at the same time. That is a fact, right? You take somebody 20% of their time away from active practice to go invent the future, right? So that it's no longer an experience where physicians and broader clinicians have really high rates of suicide and divorce and are still making medical mistakes like they did to my cousin, right, and grandmother. Yes, it worsens the shortage and increases the pressure short term. My strongly held perspective is that there are other better ways of lessening the shortage and that pressure than, forcing people to practice full time.
You went to medical school. Right? You must show up at the clinic.
Right? Yeah. And in a context where there is that level of burnout and frustration, right? If you're practicing full-time plus, right? It is a hard environment to be in. In fact, like what I observe is that when you give people an outlet to feel like their voice is being heard and they're building, maybe the model they're in now is not what they think is ideal, but at least they're using part of their time to contribute to something that they want to exist for their patients and themselves. Like that helps enormously with burnout, right? It creates some like optimism and hope for the future. Helps enormously. There's tons of things that we can do to like change the dynamics of how many physicians and clinicians that we're training. There's lots of things happening with, international medical graduates and how we think about bringing them into this country and scope of practice, which is, I know, like very contentious, and there's much people smarter on this than me. So I won't go deep into this pod, like same with like other members of the care team, but right. And there's lots of other things that we could realistically do, like within the practice context, right? To make things easier on people. Like we don't pay for certain types of specialties appropriately. Pediatrics, we could spend primary 5 of these like podcasts, right? Talking about that and the level of stress that creates for people. We don't talk about how we don't pay, like one of my colleagues, right? Her husband is doing literal brain surgery on children and cannot even afford a basic apartment in the community in which he is training, right? Wow. And a like junior associate that would be hired at the business where she works could. That is bananas. Like, I am sorry, that is bananas, right? So I think in the microcosm of things, right? Like, yes, the question is fair and right. in the macro, that is not the thing, right?
Yeah.
That we should worry about. But there's so many other levers to pull.
I'm curious, not to take this too different of a tangent, but like the AMA has lobbied to artificially restrict the number of medical graduates. They have contributed to the critical clinician shortage, and they've even worked against allowing PAs and MPs to like step up and fill the gaps. Do you feel like there is a role for clinicians to advocate for the AMA, to think about these like bigger ecosystem issues with just facing the shortage?
Yes, and many of them absolutely do. I'd say it's a community of people that are under great strain from many different angles right now, and understandably, when they are then told, well, if that happens, right, will you get paid even less, pediatrician, right? Like, well, right, like those arguments, which to be clear, I believe are very misinformed and not based on data, right? Like there is clearly like an immense like access and availability sort of like mismatch right now, where like there were an enormous amount of far more clinicians and physicians available. That it's a long time right before demand runs out, right? And people aren't going to have well-paying jobs. But like that argument is very, very scary, right? In a context where they're also being told they're about to lose their job because of AI, right? And it's very real that some institutions are like replacing large swaths of them with like nurse practitioners and others. So it's complicated, but yes, short answer to your question, absolutely yes. And I'd say in the long run of things, always in these situations, like people are better served by being proactive, right? Rather than reactive and like protectionist. Be proactive and invent the model where you can continue to lead and figure out how to solve the problem.
Yeah, be part of the solution.
People are going to go around you. Yeah, people are going to go around you and solve it anyway, right? And you're going to get left behind and not be happy.
Yeah.
Yeah, this is where, for me, the way you framed it, Rebecca, going back to this short-term, maybe short-term pain, but medium and long-term benefit, where technology, I think about a lot of underserved communities and rural communities, and as acute as the shortage is for those of us living in the Bay Area or in New York or in other parts of the country, that acuity is there, but it's magnified exponentially right in these other areas. And so I wonder, putting the AMA aside, how do you see the role of technology really helping expand the offerings and therapeutic support that those populations clearly are not getting today?
Yeah. I believe in almost like infinite opportunity for it to expand accessibility, right? And it's a similar kind of statement that I made earlier. It's not a question of if it will, it's a question of when, and gating the use cases for which it can, right? For both clinical appropriateness and, like where we think the line should be for what people can do with their own bodies. And my personal like stance is that right now that line is way too far over in, somebody else is going to decide whether or not the risk reward equation, is appropriate to try something, particularly when it's, sort of technology heavily making a decision. But again, that comes from living in a context, and as Hallie spoke about, working in a global health context where the alternative was literally nothing, right? And one of my biggest beefs when we talk about things like, even like digital health companies being evaluated is we don't evaluate them against the nothing that so many people in this country experience, or we don't evaluate them against the 6-month wait time before they get to see an endocrinologist. This drives me bonkers.
Yeah, it's crazy. It's crazy.
I'm trying to not get too intense here, but that is not the real world. It is not, right? And it shows up if you actually look at like the member. I use the word member because that's what we've called a lot of people in the programs at companies I've worked for, and the real user behavior and feedback you see in these programs. They love them and they stick with them for a reason, right? And it's why you see the unbelievable like usage levels in some of these D2C programs and products that have also received a lot of criticism, like from some parts of traditional medicine, right? Yeah. There's things to criticize, but there's very real signal there, right, on the needs that they are meeting in real people.
Yeah.
And
okay,
I do not feel they're given enough credit.
While we're talking about criticism, you have said that the value destruction of the Livongo-Teladoc merger still haunts you, and spill the tea there.
Sure. Yeah, haunts is the right word. It is the right word. So context, I worked at Livongo and then Teladoc for about 4.5 years combined. I am immensely grateful for the opportunity I had to join Livongo when I did. It was when they were just entering really kind of the growth phase of their journey. The cliche that if somebody invites you to have a seat on a rocket ship, you should just say yes and immediately jump on is like absolutely
Sheryl
true.
Sandberg,
And
right?
Sheryl Sandberg, right? Like contributed to the right person, like could not be more true. When I joined, I was responsible for the products that supported our coaching team, who, of course, they were the humans that supported our members in our chronic care programs. And when I ultimately left about 1.5 years after the Livongo-Teladoc merger, I was responsible for programs that supported 10 million patients a year and had around $2 billion in revenue coming off of them. So,
amazing.
Right, like that's an unbelievable personal trajectory and sort of company trajectory to be part of. So just wanted to say that very clearly before I get into the kind of tea part of it. Here's what I would say. I feel the writing and analysis of the value destruction that has occurred has overly focused on, if you think about like an organization as a body, the kind of like head part of the problem. Look, what's happening right now with like independent like media and reporting is atrocious. So like, please don't take this in the wrong way. Like deep respect for those individuals. They need to be supported. I've been contacted by almost every reporter who's written anything about this merger. They only want to talk about Glenn and Hemant. Like, they're all looking for the, like, who's the villain in this? Like, who screwed who over? Did Jason and Glenn hate each other sort of angle? Yes. Like, it mattered that whatever happened between them, that mattered. It mattered that a bunch of the senior leadership left right away and they couldn't figure out how to create space for everybody and got along. That absolutely mattered, right? What also mattered were all of the heart and body problems as part of the merger. And nobody wants to talk about that or write about that. But that is relevant to every single big M&A process that is going to happen within our industry. And it is worth talking about and learning from, because otherwise we're going to keep mispricing.
Making the same mistakes.
All of these M&As, right? And
which we need. We need these acquisitions to work out.
Please, like as a VC now, can we please like continue to have more of these, right? Like please. We need, and we are absolutely throwing like the baby out with the bathwater in terms of what both Teladoc and Livongo really, really got right and continues to be right in the combined organizations. And I also let's talk about the sort of like body internal organ problems and like what went right within them, right? Because that's what my team was, right? Like we were the people who like designed, built, and brought to market the products, the like Mountain View, Evelyn Avenue team, which to be clear, Hemant, like legendary. I hope that Scrub is half what General Catalyst is when I retire someday, but I never saw him ever in the Mountain View office. So like whole part of the story, right? Yeah. Like had nothing to do with anybody. He's got work
in my hometown in Ohio to do.
He's got way more to do over there, right? Like different part of the story.
Hey, don't knock Mountain View as I'm sitting here in Fenwick's Mountain View office today. I can see the old Livongo office from here.
Let's tell the Mountain View story, though. The Mountain View story needs to be told. Okay, so first of all, let's talk about the baby that shouldn't be thrown out with the bathwater. Jonathan Bush, wonderful Jonathan Bush, recently described the two companies as like two turds that came together, right? Recently in Med City News. Here's the thing, Jonathan.
I didn't read that. I've heard tying two rocks together and hoping they float. That's how I've heard.
So unlike companies like, say, electronic medical records or infrastructure companies, when people purchased Livongo or Teladoc, we didn't really get paid unless somebody actually used the products and kept using them. And we did. You saw people using them year over year, both on like the member side within one program and signing up for more programs and continuing to use them year over year. And that's how you saw the unbelievable hypergrowth that occurred on the side of both companies, right? And that you can both see that in the revenue trajectory of the individual companies And even now, years later, as a VC, like these companies are still shown to me all the time in decks as like the best in class for upfront activation and long-term engagement. And I don't want to spend like the rest of the podcast going into the hyper-specific details of what we did in these products that spoke to people who tended to be middle-aged and older, really quite sick, right? Like multiple chronic conditions. But it is worth spending the time to understand it. And for what it is worth, a lot of the best entrepreneurs out there that are building long-term programs for people who are quite sick still contact me all the time to understand it. So like you are doing a real disservice to yourself if you look at this and say just because the stock price crashed and the merger didn't work, these companies were turds. Like I will take my sterling turds to my grave and be proud of them. So like, do not listen to that. Like, okay, they were good products that people used and valued and sustainably stuck with, both on the client side. So what happened to the body and the internal organs, right? Like post-merger, largely stopped inventing new things in a material way, largely stopped shipping and even close, right, to the velocity that was occurring previously, and stopped selling at the same velocity. So it went from being a technology company that was working in the way that I described earlier, where you had this magical collaboration between designers and clinical, like, and engineers and commercial that were all best in the industry at what they did, with, you know, a real like visionary, experienced set of leaders at the helm, to being a big company that was working incredibly ineffectively together, like up and down, working ineffectively together, right? Like, and I don't work there anymore. I haven't for a while. Like, there's still good people there. So I'm just reflecting on sort of the year and a half that I stayed, to be super, super clear. They're doing some good things now. But here's a couple of the things that I would be like share really, really specifically. I feel that if you're going to merge two large organizations, pay a really, really high price, like you need to be ensured you get this right when you're putting a big valuation out there. Because of course, when you're thinking about valuation, it's not just like, we heard the word synergies a million times in that 6 months after the merger. Like I puke when I hear it now. There were a bunch of assumptions on the synergies that I still believe were like really, really right in their scale. They were really, really wrong in the timeline and execution complexity to actually capture them, but they were knowable, right? They were probably knowable before the merger, and that should have impacted the price. And so they're things worth understanding for others, like contemplating similar things. One, very obvious at face, Livongo was fundamentally it was a technology company, right? Like it showed up in the margins, it showed up in how it was run, right? It showed up in like the specifics of the product, and you were lumping together a technology company with I deeply do respect Teladoc. Like they were fighting the good fight to provide virtual care with the state of Texas, like when everybody else was like, no, virtual care only matters for people in rural Wisconsin, otherwise like don't do it. So like great respect. But it was a services company, right? Lumped them together and pretended that you were somehow going to get a technology company out the other side within a few months. Bonkers, right? Like we priced it as if that was going to happen when you put them together. That makes no sense on face, right? Don't do that. Two, a ton of assumptions about being able to upsell each other's clients almost from day one. You could have looked at the contracts, right? And talked a bit to each other and realized that each other's clients were buying totally different things, and many of them were incredibly clear, digging their heels in around buying anything close to like physician level care, especially on the Livongo side. And we knew that because we tried to add physician level care multiple times to the product over the preceding 18 months, particularly during COVID. And I in particular got in trouble several times for like trying a couple of different like feature sets, like to, in doing that, even though the patients loved it, like the client side didn't. Very, very knowable. Can you actually enroll each other's patients across different products, right? And like this was an issue at the level of like legacy tech debt that was knowable and not talked about prior to the merger. Like on the Teladoc side, they actually couldn't tell that, patient A that was from the same client was the same patient from like different products that Teladoc owned, much less that was the same patient now over in the Livongo product side. So like super mundane stuff, right? That you had to actually talk to the operators inside the company to figure out. totally solvable, but took a really long time, like addressing that tech debt to solve. And by that time, right, the market had been told a different story about how quickly all of these members were going to start, being upsold and enrolling in the different programs and what the revenue spike was going to look like. We got there, but it was too late because it's all about setting expectations, and then it was too slow. And then we talked about like the people part of things, right? What had actually happened is it wasn't just Livongo and Teladoc as two entities and like products coming together. Teladoc had gone on an acquisition spree in the preceding years with other smaller companies that had, really, really great products. A couple of them in particular, when you dug in and saw how much clients loved them and patients loved them and some of the impact it was happening, incredible. But it was more like 6 different organizations and 6 different products were coming together in like the mega merger for the ages. Again, like the market expectation setting to pull something like that off, totally off. So the reason this haunts me is I still strongly feel, and when you talk to people who are still there, honestly, like they still feel this strategy is the right strategy. And it's the reason that the clients that Teladoc still has, they're still buying, right, and sticking with the products. They've had not that much churn when you really look at their numbers. They still believe in this strategy. It's just taken a really, really long time to execute on it. And in the process, because of some of the leadership missteps and what's happened to the stock, you have this domino effect, right, of losing all of these people, right? And fundamentally, these companies are about the people. So it is a deep sadness to me. And it was not a turd situation. It was a massive missed opportunity situation.
What do you think would have happened had Livongo stayed independent? Do you think they would have eventually just outpaced Teladoc in growth, or?
I believe that Livongo would acquired something else or merged with something else. This is hard because I have other insider information about what we were otherwise contemplating to do. I believe we would have pursued a similar strategy with a alternative
with a type of
partner, right? But the economics at play, how it turned out.
Yeah, Rebecca, there's just so many learnings, and the integration challenges. I mean, Hallie's phrase is the right one. I use it often when we're looking at M&A, tying 2 rocks together to see if they'll float. Neither will float by itself. So, hey, let's tie them together and see if they'll both float together. But it's very, very clear, as I have the privilege of working with so many later stage private companies now, that they've taken the learnings and the lessons from mergers like that. And now they've got integration leads in their organization that before they make an acquisition, they're diving into many of the challenges that were identified in that deal after the merger, right? So let's get out in front of these issues. And so I do think the market has learned. Now, they don't have the level of detail or obviously the inside baseball that you do on that particular merger, but I do see more and more in our M&A practice here at Fenwick that many of our serial acquirers, whether they're public companies or in many cases now, very large unicorn valuation companies, they do have an integration strategy, and they bring that group and that team to the table as the term sheet is being negotiated, because that's a fundamental valuation consideration. And so we've learned. I mean, our industry has learned from that. I mean, maybe not all, but I'm seeing it as I have the privilege of sitting in board meetings day in and day out and week in and week out at some of these very large late stage valuation companies. And integration is a key consideration and topic at the top of the agenda when exploring whether a particular acquisition makes sense or not.
So look, you have, of course, far more exposure to those conversations than I do. My impression is that we have not had M&As that are not 2 rocks that can't float independent. We've had M&As that are what Hallie is describing. Teladoc and Livongo were not 2 rocks that can't float independently.
Right.
Right? That is where I think people do not do a good job. It's when you want to get a deal done, everyone's excited, and you want to tell the market a big story and it's bombastic, right? I don't know. Maybe you have an example of one that fit that kind. I mean, there hasn't been one of like that scope, right? But like that would fall into that category, right? Where people don't. My experience has always been like people don't want to be patient and they don't want to hear bad news. And I've been on the side of the table, even inside good organizations, talking to the CEO, delivering this kind of news and they don't want to hear it. Like they don't, right?
Yeah, that's the problem with deals. Momentum sometimes picks up to such an extent that, you start brushing aside or under the rug, whatever the right phrase is, issues. But I do think I am seeing, and look, the reality is in our health tech sector, we do need more headline grabbing transactions like that. I think we have had far too few in our industry. But what we are seeing right now here at Fenwick is a lot of roll-ups going on, Series C, Series D companies, coming together. There's all sorts. Hallie and I've spent ad nauseum numbers of podcast discussions around the challenges there. But I do see learnings that are being taken from some of these less optimal outcomes and incorporating them into the next deal.
That warms my heart to hear. Yeah, I'm so happy to hear that. Good,
by the way, it doesn't mean we've got it solved, but we're at least these are topics that are being had up front and not post the acquisition.
Nobody wants to write about it and talk about it, but I'm glad that it's been learned behind the scenes and people are doing it. The one last thing that I would say that I actually do believe people have learned from this experience, people who are in it and part of it, because I hear it from the leaders actually, many of the ones who sort of left in the first 6 months, is the recognition that for their companies to survive over the long term, which looked like to be clear, these people wanted Livongo to survive over the long term. And that's the other accusation that I've seen in the media, which is like not true and not fair. Point blank, right? Knowing these people well, is this belief that these companies need to remain founder-led beyond the point of some of these mergers. And I've heard a lot of real soul searching and contemplation of what that needs to look like after they go public, right? Once the M&As happen. And, what does that mean in a context where maybe the public markets expect a certain kind of CEO once a company goes public? Is that actually the right kind of CEO if it's going to continue to be a high growth tech company? I mean, the Livongo IPO is another really interesting example, right? They brought in Zane. All of us knew Zane wasn't the one that look, Zane's wonderful, to be clear, but all of us knew Livongo, Zane was brought in so the market felt comfortable with us going public, but he was in no way the person that was this is the vision, this is where we're taking the company. That continued to be Glenn and Jenny. Everyone knew.
Yeah.
So this is another problem, right, that we have on these companies.
So now, I mean,
that's a whole nother podcast.
I know. It's so fascinating you're right. I mean, most of us only learn, about these stories through the media, and the stories that do well in the media are the ones that are the most sensational. So we don't necessarily get to hear the full story. So so appreciate you sharing. Now, just to tie it back to what you're doing now, because now you're an investor with Scrub Capital, and you need these sort of acquisitions to continue happening in order to see a return and continue to invest in great companies that are adding a lot of value. So what are kind of some of the things that you're bringing to Scrub? Give us the pitch on what you're doing, and let's use the last time that we have together to just talk about Scrub Capital because it's so cool.
Yeah, absolutely. Yes. Thanks for giving me the opportunity to talk about it. So Scrub. So Scrub, again, comes from a similar place where it's, okay, how do you bring together people who are going to think from first principles, bringing their unique, spiky expertise to reimagine what could be possible when it comes to impacting human and eventually, right, for Scrub Planetary Health, we're focused on human health in the early days. And when we, myself, my partners, Chrissy Farr and John Slotkin, and I looked around, at least the early stage VC industry, we felt like there was a real opportunity to do what I had done for all these years, really in product work, and bring in the heart and the expertise of clinicians, particularly clinicians who've really leaned in over the last 20 years to be early adopters of technology in healthcare. And that could mean they were early adopters as founders, building some of the really successful technology companies over the last several vintages. They've been high-profile, successful executives in some of these companies, or they're really talented technologists, or they're senior leaders in some of these health systems. So we've put together a 700-ish now member community of those folks and stood up a VC fund alongside of them. And they're materially involved in us finding seeing early stage healthcare opportunities. They're really closely involved in evaluating them for us to make an investment. And then once we've made an investment, quite supportive of the companies in the earliest days. So we don't think about ourselves as like rebuilding an early stage incubation platform or anything, but think about ourselves as a really spiky, differentiated partner alongside other high quality early stage investors.
And Rebecca, what's the typical check size look like for the fund?
Yeah, for Fund 1, it's a couple $100K. So our LP base is also not only, but it's predominantly clinicians. The other piece of our mission is to give clinicians more opportunity to experience being a limited partner within a fund and more education and being an early stage investor. Something that we heard a lot of is that many of them, had tried angel investing, and maybe to your point, Hallie, right? Like a lot of them, they don't want to leave practice, right? And they'd read enough about it to know that you need to create a pretty big basket of individual investments to have kind of appropriate risk exposure as an angel investor. And so we stood up a fund so that they can have that, kind of high volume exposure across many deals, but still have that influence as a group on what we're investing in. And then we're usually getting allocation alongside the fund check so that those that want to put in individual checks to get more exposure to that individual deal can still do so. So a couple $100K for Fund 1, but in the future, as we raise, higher AUM funds, we'll go bigger.
And it's nice that when you say clinician, oftentimes, and you're a doctor, we think MDs, but you've defined it broadly, right? They're not just clinicians in terms of doctors and nurses, but like I'm a public health professional and you allowed me to join the group.
Yeah, so we, from day one, felt it was incredibly important for this group to represent the entire care team, right? I mean, we need the entire care team for healthcare to function. And I'm a big believer that when I think about the care team is not there only to, enable the physician either, right? Like, for example, right, like I very intentionally went and had my child in an environment where it was a midwifery led practice. Kaiser Permanente has one of those areas down in Redwood City. So we very much believe in having RNs, NPs, dentists, pharmacists, PT, OT, like lots of different folks with different specializations at the table. We're really intentional about bringing in people who have different contexts for where they practice. So private practice, AMCs, large integrated systems, kind of working hard to have a lot of diversity and practice experience in the group.
No, and what I love about this, Rebecca, is also the unique skills that you can help your portfolio companies by exposing those companies to this incredible depth of expertise you have in these 700 clinicians. I mean, it's not something that venture capital firms are typically well skilled at doing. And like, I got to imagine there isn't a single specialty or therapeutic area of focus for these portfolio companies of yours that you don't have at least a handful of experts within your LP base who you can deploy to help these companies. I think that's
it's like having strategic angels without having a cap table that's like 5 pages long.
Exactly. So it absolutely feels like kind of a cheat code, like as a GP in the fund, where previously I'd be, like working affinity in the Rolodex and doing a ton of phone calls and emails. And now it's just literally like I throw something into Slack and then the absolute perfect person is like raising their hand within 5 minutes or DMing me, right? Or, sending me an introduction to the perfect person at their institution. That's exactly right. And, we have, as part of our process, we have what we call our community pitch events, where we're both inviting these individuals to come in and see a presentation from a opportunity we're looking at. And we're also doing a bit of hand curating, right, and reaching out. And so often after these pitch events, the founders will contact me and they'll say, Rebecca, just to be clear, like I would have paid for this even if like there wasn't a check available, right? Like I had no idea you were going to have 7 urologists that are exactly like my target client profile showing up today, and I'd be able to talk directly to them and like ask them questions. So really like the model sells itself. It's really, cool. Really wonderful. Yeah.
Well, we're up against time. We have to ask you our favorite question to close, which is if you could wave a magic wand and change one thing about healthcare, what would it be?
Ooh, so many things. But I will tell you, like the first thing that jumped to mind when you asked that question, should have been better prepared. I wish that all of us working in healthcare were more supportive of each other. We do this thing in our industry where We are so much more critical of each other and things we try and the way we try to solve problems, right, in our position in the ecosystem than others outside of the system are, right? And we shouldn't do that. Like, we are taking on such hard problems, like from like the biological end of the spectrum all the way through to, you know, like what Congress is doing and potentially massively cutting Medicaid. Come on, like we're so much more alike, right, than we are different. I would love to see that change culturally.
Yes. Love that.
Amazing.
Well, thank you so much for having me on.
Thanks
Really
for joining
appreciate
us.
Thanks, Rebecca.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.
You set the gold standard for your business. Your website should do the same. Wix puts you at the helm so you can enjoy the creative freedom of designing your site just the way you want. Want someone to bounce your ideas off? Talk with AI to create a beautiful site together. Generate on-brand content, images, media, and simply change or fine-tune any of it along the way. Whatever your business, manage it from one place and tie it all together with a personalized domain name. Gear up for success with a brand that says you best. You can do it yourself on Wix.